most people are aware, but it helps level set. We currently have the Vermont all-payer model agreement with the Centers for Medicare and Medicaid Services. There are 3 Vermont signatories to that agreement: the governor, the Secretary of AHS, and the Green Mountain Care Board chair. And what this arrangement really does is allow Medicare in particular, but also Medicaid and commercial insurers to pay for health care in a different way than fee for service. And it also establishes state level accountability for cost, for population health, and for quality. And you'll see that accountability framework when we get to the proposed future model, that's a construct that's in the future model as well. The idea is to offer providers predictable prospective payments, to link those payments to quality. And the goal of payment reform really is to support care delivery transformation. The goals are to reduce healthcare cost growth, to maintain or improve quality and improve the health of Vermonters. And again, you'll see those same themes reflected in the latest proposal from CMS. In our current model, we rely on an accountable care organization. In this case, it's OneCare Vermont, to develop that voluntary network of providers. And those providers have agreed to be accountable for the care that they deliver, cost, and quality for the folks who are attributed to them. The model's original performance period was 2018 to 2022, so it was a 5 performance year model. We're currently in the first year of a 2-year extension that was suggested by the CMS Center for Medicare and Medicaid Innovation, and we approved that extension in November of 2022. We were expecting at that point that there would be a future federal model proposed for implementation in January of 2025. That has changed. The earliest date is now looking like January of 2026. Our current model is set to end at the end of 2024. So next slide. We like to remind ourselves of why it's important to continue including Medicare in Vermont's healthcare reform efforts. And I mean, first of all, Medicare is obviously a very significant payer in Vermont and elsewhere. But having continuity and having Medicare participate in healthcare reform really allows us to do a number of things. It allows for continued recognition that Vermont is a long time low-cost state for Medicare. Some of the other states that are involved in healthcare reform may be higher cost states, and so Medicare can customize a bit for states that are low versus high cost. It also allows that continuity, allows us to continue to recognize some of the savings that have occurred in our prior healthcare reform efforts, the current model, and also the Blueprint for Health model that's been in place statewide and with Medicare's participation since about 2010. It allows us, again, as a big payer, it gives the state some ability to influence Medicare reimbursement for Vermont providers rather than just accepting fee schedules and such. An important component, I think you've talked about this recently, probably as recently as this morning, the model does provide more than $9 million annually for the Medicare portion of the Blueprint model. And that goes to primary care practices in the form of patient-centered medical home payments. It goes to regional community health teams that provide additional services for people with complex health and social needs. And it also really is the key payer for the support and services at home program that works with Medicare beneficiaries through housing organizations. And CMS has indicated that should we, continue to participate in a future model, that those payments would continue. The Medicare does also in their models sometimes allow for waivers of Medicare regulations. One example is there's a requirement that there be a 3-day stay in a hospital before a person with Medicare is admitted to a skilled nursing facility. That's waived under our current model and other models. And so that flexibility in coverage and care delivery from Medicare can really help move things along. And then finally, last but not least, having alignment in payment models, quality measures, priorities across payers really is supportive of our health system partners, our provider organizations, and it really sends a strong signal about what our goals are. Next slide. So we've had, with Green Mountain Care Board, have had conversations with CMMI over the past many months and have really reflected feedback that we think is important in a new model that includes support for rural provider stability and sustainability. And of course, we've talked about workforce and healthcare inflation, and these are not just Vermont concerns. They're hearing this from other states as well. It's important to have predictability in payments, and that does seem to be a cornerstone of this model. It's important that there is recognition that some states are low cost, and so the right amount of revenue is included in those payments. Support for investment in preventive and community care is critical. We want to make sure, as I just mentioned, that payment models and quality measures are aligned across payers as much as possible. And we have really advocated that Vermont be supported in moving forward on important healthcare reform efforts that have shown success in our state. Next slide. So in addition to talking with our federal partners, we have also, again, with great collaboration from Green Mountain Care Board members and staff, we have, engaged pretty deeply with state partners. And so we have an advisory group structure right now, the Healthcare Reform Work Group, which has been meeting monthly. We're going to up the pace a bit during this time, but that's sort of the broader group. And then beneath that, there are 4 subgroups that have been meeting. The Global Budget Technical Advisory Group, Robin Lunge is my co-chair on that group. The Medicare Waiver Technical Advisory Group, the Primary Care Advisory Group, which was actually suggested by primary care providers, the Payer Advisory Group. And, before, these groups have, been meeting for a few months now, in the case of some of them, many months. But in the summer and fall of 2022, we also had some other groups that were meeting, first of all, to really talk about short-term provider stability with some of the challenges we are seeing in workforce and other areas. There was a group that talked about broader global budget and a group that talked about total costs of care. And those have all helped to inform the work as well. Next slide. This just goes into a bit more detail on how we've, engaged with state partners. But, again, the summer of 22, that short-term stability work, fall is when we really started with that global budget group and the total cost of care group to, start to outline some principles and get input on a framework to begin our discussions with the federal government. And then in February of 23, the more detailed work began on the hospital global payments and the Medicare waivers. The primary care and payer work groups started later. Throughout 2023, we've engaged in discussions at existing forums. So examples are the Dale Advisory Board, that AHS convenes, the Mental Health Integration Council that the Department of Mental Health and the Vermont Department of Health have co-led, and then the Green Mountain Care Board's own primary care advisory group. In addition, throughout 2023, mechanisms for public input on both the Green Mountain Care Board and the AHS websites. These regular updates that we've been providing at your board meetings, and then numerous meetings with provider and other groups. Get a lot of invitations, and we're happy to talk with anyone who wants to learn more about the potential future model. Next slide. And the next. So that brings us to, the new model, the AHEAD model. It stands for States Advancing All-Payer Health Equity Approaches and Development. And I want to just emphasize the centrality of health equity in this new model. So what's happened is that CMS, or its Innovation Center, has decided that will now offer only models that more than one state can join. Currently, there's a Maryland specific model, there's the Vermont specific model, and there's a Pennsylvania specific model, but they really want models that more than one state can join. And so we had gotten some information on what the new model might look like, but more details were released on November 16th in the form of what they call a Notice of Funding Opportunity, and I'll refer to it with its acronym from here on, NOFO. Within that model, or within that document, they indicate that states, there's 3 cohorts, and I'll get into the timeline in a minute, but states that want to participate in the first 2 cohorts, which the first one would have that start date of January of 2026, would need to apply. It's a competitive process, would need to apply with applications due on March 18th of 2024. CMS will select no more than 8 states for this model. So it's either entire states or states, and states are the applicant, or it could be a sub-state region, but they will take on no more than 8 states for this model. Again, earliest implementation date of January 1, 26. What that means for us is that, our plan is to apply, but you have to apply, be accepted, feel like come to terms on a state level agreement. So there's a number of steps before it means that there would actually be participation. But what that means is that if we were to apply, and if we were to get accepted and start on January 1 of 2026, the current model would either have to be extended, or likely we'd revert to fee-for-service payments from Medicare. So CMMI has definitely indicated that it's interested in extending our current model through 2025. So we're negotiating what that will look like. And they have most recently indicated that they do have approval to extend that model for another year. Next slide. This is the timeline for the 3 cohorts. I've mentioned the due date for applications. They have asked, but not required, states to submit a letter of intent. if they plan to apply. That deadline is February 5th of 24. And then you can see here the three cohorts. Cohort 1 and 2 applications due on March 18th. The difference there is when the model would actually start. For cohort 1, it would start in 2026, cohort 2, 2027. Cohort 3 states would have, a little longer. I think it's August of 24 that they would have to submit an application. And like cohort 2, the model would start in 2027. So that's sort of the timeline that we're looking at for application and start of the model. They have said that, I mentioned 8 states. They've said that 5, no more than 5 will be selected for cohorts 1 and 2 because they want to allow some spaces for cohort 3 states. Next slide. This just is a statement pulled right from that NOFO about what the goals of the model are, and just felt like it was worth emphasizing. So, again, similar to the current model, curbing healthcare cost growth, improving population health, and advancing health equity by reducing disparities in health outcomes. So they really focus, it's the triple aim of healthcare, but they really focus that improving quality on advancing health equity. So again, the centrality of health equity to the model. Next slide. This is a rather busy slide, but it's a CMS slide. We pulled it right from their materials, but it does do a good job of describing what the AHEAD model is at a glance. So there's really, they outline that there are 3 layers. The first, and I want to spend a little bit of time here, is on statewide accountability targets. So what if the state is selected and a state decides to pursue the model, what would the state be held accountable for? And so there's 3 areas: total cost of care growth, and they want from both Medicare, traditional Medicare member costs of growth, cost growth, and then all payer cost growth. A second area is primary care investment, same 2 stratifications for that measure as well. And then they want to see population health outcomes with targets and equity targets as well in the state agreement. So this is not wholly unfamiliar to Vermont. We have a total cost of care growth construct and targets in our current model. We certainly have a quality framework. The primary care investment is new. The focus on equity is new. And then, I didn't mention it in the timeline, but this is a longer model. It appears that they have learned from experience that this level of transformation takes more time. So this model goes through 2034. So depending on the cohort, it's either 9 performance years or 8 performance years. So that's the statewide accountability layer. The components of the model that they are proposing and have developed to help achieve those targets are, first of all, cooperative agreement funding. So they want to give states funding that participate in this model. It's not a ton of funding, but it's $12 million up to $12 million per state that is selected, and that would be over 6 years. So an average 5 to 6 years, so an average of a couple $1 million a year, and that is intended to support transformation. Hospital global budgets are another key component for inpatient and outpatient services, and then primary care AHEAD. And we'll talk about each of these in just a little more detail. And then they outline the strategies that they think are going to be important to support the implementation of those components and to support the achievement of the targets. Next slide. Act 167 actually outlines some elements to be considered for a future model. And I just wanted to note that several of those, really most of them or all of them, are included in the AHEAD model. So Act 167 talks about total cost of care targets. That's in the model. Global payment, and with a particular note on hospital global budgets, that's in the model. Strategies and investments to strengthen access to primary care. There is a primary care component, and to strengthen access to mental health and substance use disorder treatment services. There is an emphasis on integration of mental health and substance use disorder care into primary care and hospital care. And then strategies and investments to address health inequities and social determinants of health, and that's infused throughout the model. In terms of home and community-based services like home health, mental health, substance use disorder treatment, subacute services, long-term services, and supports, there's less specificity or detail in the model. However, there is a statement that, the aim is really to support hospitals in transforming care delivery and shifting utilization to primary care and community-based settings where appropriate. And there is, discussion of really building those partnerships between different provider organizations. Next slide. I did want to spend just a minute outlining what is required in an application to the AHEAD model. So it's broken into essentially three areas: the project narrative, a budget narrative, and appendices. And you can see here the types of things, and there's a lot of detail under each of those. I will note that we're limited in the project narrative, for example, to 60 pages, double spaced, 12-point font. There are definitely limits on the narrative. But you can see the types of things that they're looking for here. Organizational capacity. What's the state's capacity to actually do this model? Are we looking at the whole state or sub-state region? What's our strategy for measuring those statewide accountability targets? And we have some experience, and your board in particular has some experience in those areas. What's the plan to recruit hospitals to participate in the hospital global payment portion of the program? And what's the, how will a global budget methodology be developed? What's the vision for primary care transformation? And this speaks heavily to the work that our primary care providers have done around the Blueprint for Health and other initiatives. What's the plan to recruit primary care? What about, because data collection is going to be important in this and any model, what's the infrastructure for health information technology and data collection? What are our state's current and planned health equity activities? There's a model governance structure, which Wendy will speak to a bit. And then how will there be alignment with commercial payers? And then under the budget, how, what would those cooperative agreement funds be used for? So there's there's quite an outline for the application. I will note that there is a requirement that at least one hospital provide a non-binding letter of intent as part of the application. Next slide. So we use this slide to say, here's the key components of the model. And, it's evolved over time as we've gotten more information, but I want to spend just a few minutes on hospital global payments, on primary care AHEAD, and then on the statewide and provider level accountability targets, and then turn it over to Wendy to talk about health equity model governments, cooperative agreement funding. So next slide. This is again a CMS slide. It outlines what they see as a hospital global budget under the AHEAD model. A couple notable points. The baseline for the budgets would be based on past net patient revenue for within a hospital, and that would be for inpatient and outpatient services. They're not yet contemplating professional services in their version of the global budget. There would be adjustments annually for things like inflation, population demographic changes, and if hospitals have service line changes as well. And then again, there's that statement that really speaks to transforming care delivery, shifting utilization. And then they outline a number of what they see as incentives for hospitals to participate in the model. I'll just highlight a couple of those. The first one is that CMS is
Pat, you're on mute for some reason.
Okay, can you hear me?
Yes.
Okay. So I wanted to just highlight a couple of these incentives for hospital participation. The first is a transformation incentive. And that would be for the first 2 years of the model in the Medicare, in the CMS version of hospital global budgets. And they're talking about 1% of revenues for Medicare, traditional Medicare fee-for-service members. So there would be that incentive. Clearly, we talk about this a lot in any payment reforms, but financial stability and predictability is certainly seen as an incentive. There's an opportunity, again, with that focus on health equity for hospitals to have, earn upside dollars if they're able to improve health equity and quality as well. So, but that real focus on health equity. And then again, the use of Medicare waivers to support care delivery transformation and engage some of those non-hospital providers. And Wendy will speak to that a little more. Next slide. So, that's for the CMS budget methodology, and I've just sort of reprised some of those elements and a couple more here that, prospective, predetermined amounts to cover inpatient and outpatient hospital services. Payment, they do want to, again, with the focus on equity, they want to adjust those payments for social risk and for quality. So if a hospital is serving a particularly vulnerable population, there could be adjustments in the payments for that transformation incentive. And then they will also look a couple years into the model to adjust for total cost of care. So they'll be looking at the traditional Medicare members in the hospital service area. How are they doing on total cost of care, not just for the hospital services, but across all Medicare Part A and B type services. And then they'll adjust as well for effectiveness, and they're defining that as reducing avoidable utilization. So that's what we, those are all elements in the CMS methodology. The shaded box is really important for Vermont because what they're saying is that states that get selected, if they have statewide rate setting or hospital global budget authority, and if they have experience in value-based care, all of which is the case here in Vermont, then states can design their own hospital global budget methodology. There's principles there's expectations and CMS would have to approve it, but it does provide some important flexibility for states that would want to take advantage of that. Next slide. And this is what we know about that at this point. So what is CMMI saying about a state design methodology? And you can see the list of factors here. They're really principles for alignment, but a couple that I'd really like to highlight are that first of all, in that fourth bullet, they say that there need to be the accountabilities for total cost of care and for quality. They do suggest that there could be similar metrics. There might not have to be, it might not need to be complete alignment with the CMS hospital quality programs if states were interested in proposing similar metrics. The transformation incentive, they don't say it has to be what they're saying, the 1% increase in year 1 and 2, but that there need to be some kind of incentives to recruit and retain hospitals. And they also, in that last bullet, specific to critical access hospitals, they note that states can propose modifications, risk mitigation for critical access hospitals, but they are very clear that payments will not be fully reconciled back to costs or fee for service. But, this is some enlightening information about the type of alignment they'll be looking for in those state designed hospital global payment methodologies. Next slide. So let's talk a bit about primary care ahead. So we'll go to the next slide. Primary, this again is a CMS slide. They're really outlining what their goals are for primary care ahead. It's to increase primary care investment, which is a big deal and a notable goal of this model. They want to have payers aligned. And one of the big ways they focus on this in this model is that what is Medicaid doing in terms of care transformation, and Medicare would like to be at the table. So in a way, they're suggesting that Medicaid programs lead on primary care transformation. They definitely want to support advanced primary care, and that's an area that we're pretty familiar with here in Vermont. We've been working on that for a long time in terms of the blueprint. So they're talking about mental health and substance use disorder integration of care, care coordination, really looking at health-related social needs in primary care. And then they a key focus in this model is really ensuring broader participation, particularly from safety net providers. So not only critical access hospitals, but also FQHCs and rural health clinics. The shaded box at the bottom, want to highlight that. CMMI is definitely planning to introduce a capitated payment track for primary care in the future. They did not get there for 2026. And we have some of that work that's occurred, through the ACO model with our independent primary care practices. So really trying to focus on whether that type of thing could be continued should Vermont be selected and decide to participate in the model. Next slide. So this really outlines what, again, a CMS slide outlines what they plan to do. First and foremost, so it's a fee for service program, but they want to provide an enhanced primary care payment for those practices that participate. And they're saying it'll be an average of $17 per traditional Medicare beneficiary per month. and that a small part of that, they are talking about starting with 5%, but scaling it up to 10% of that payment would be, based on quality performance. They've also said that the floor will be $15 PBPM and the maximum will be $21 PBPM. So there's the ability to earn more than the $17 average. Really important in terms of the requirements. Practices that participate have to also be participating in this Medicaid programs, patient-centered medical home, or other primary care alternative payment models. So in our case, that would mean the Blueprint for Health, and most of our primary care practices do participate in that program. And then I'll speak to this quickly in the next slide, but there are specific care transformation requirements that would be expected of practices that participate. I'll also note that for hospital-owned practices, if they want to participate, the hospital has to be participating in the hospital global payment program in this model as well. The one exception to that is that if a hospital owns rural health clinics, the rural health clinics could participate even if the hospital isn't. And that again is CMMI trying to get those safety net providers in. And then they talk about how that funding can be used: infrastructure, staffing for advanced primary care, and so forth. And that's, again, something that's quite familiar to us. Next slide. This is the transformation slide, and I, look at these as examples. Maybe we're not sure that they're requirements. We think the, Venn diagram is requirements, but the text boxes might be more in the example realm. But again, they're talking about mental health and substance use disorder integration, screening and addressing health-related social needs, and care coordination. These are all some pretty strong centerpieces of our Blueprint program, and even more so with the Blueprint expansion pilot that's underway right now. So this seemed encouraging. It didn't feel like new requirements, given all that our primary care providers are already doing. So next slide. So I'll just spend a minute on statewide and provider level accountability targets before turning it over to Wendy. I will note that there are slides in the appendix that really get into more detail on what CMS is proposing as potential measures. Next slide. So there's really, the framework is that there's three areas of accountability: statewide accountability, and we've talked a bit about that already, the quality and equity targets, total cost of care, primary care investment. There's also a requirement that in year one, at least 10% of Medicare, fee-for-service, or traditional Medicare hospital revenues are under a global budget that increases to 30% by year 4. So there is an initial, sort of scale type of requirement. And then the second big category is, and on the payer side, at least one commercial plan by year 2 in the model. And that could be any kind of a plan. It could be, qualified health plans. It could be a self-insured plan. It could be state employees. So, but at least one plan in the model by year 2. Second is the hospital level measures. And so that, again, we have a slide that provides a bit more detail in there, but really looking at CMS's national quality programs, that health equity bonus that we mentioned earlier, and then those adjustments that they're talking about making to payments around total cost of care and effectiveness. And then finally, primary care. They again outline some potential, their ideas for measures there, and that payment adjustment based on quality performance. And we've always sort of taken this approach, and I would say we've been somewhat successful for it, and there's always room for improvement. But the more that we can align across all those areas, the better. If we can identify what our priorities are and really try to align in a way that encourages us all working together on quality improvement. Next slide. The first part of this just reprises what I just said with a direct quote from the NOFO, but I did want you to see these domains that CMS has outlined, and then there are corresponding goals and measures with each of them, but they're really looking at prevention and wellness, population health, and that has a focus on chronic conditions, mental health and substance use disorder, what they call behavioral health, but we call it mental health and substance use disorder. And then that healthcare quality and utilization, that's where you get into that effectiveness on the avoidable admissions and readmissions, and then also improving a person's experience of care. So that's how they're looking at it, is by domains. Next slide. So I am going to, if it's okay with you, turn it over at this point to Wendy to talk about a couple of the other areas in the AHEAD model, if that works for the board.
That'd be great.
Thank you.
Thank you very much. The AHEAD model has built-in structures to ensure advancing health equities at the forefront of this model. So each state that's selected to participate in the AHEAD model will need to establish a model governance structure. This has a key role in developing and monitoring health equity strategies. The structure could build on pre-existing work groups or boards and can have an advisory role. The required role within this model is quite extensive and technical. I'll get into more detail on the next slide, but we'll note that it includes providing input into the selection of statewide population health and quality measure and equity targets, developing the statewide health equity plan and producing annual reports on progress implementing the health equity plan, assisting with the review of the hospital health equity plans, and providing input on the use of the cooperative agreement funding. Representation must include the state Medicaid and health agencies in a leadership role, and they'd be bringing together individuals representing the groups here. So patients and advocacy organizations, community-based organizations, payers, providers, local tribal communities, and the State Office of Rural Health, and other partners, such as those who are really experiencing health inequities in those populations who are impacted by policies. Next slide. So the AHEAD model, really it includes key strategies and activities to advance health equity across multiple sectors. The model governance structure has a significant role in planning for and monitoring all of those activities. So the 4 boxes on this slide depict the health equity related activities. The state, working with that model governance structure, will be required to develop a statewide health equity plan that will define and guide the model activities aimed at reducing disparities and improving population health. We expect CMS to be providing a template on what this plan will look like, but we expect it to include things like identified health disparities and population health focus areas, measurable goals, evidence-based strategies to advance towards those goals, and the processes to involve a wide range of stakeholders in implementation of that plan. This plan has to be established by the end of the pre-implementation period and then updated periodically. The next box is related to hospitals. So participating hospitals will be required to develop health equity plans. Those would be detailing observed disparities and identify approaches and resources that will be used to advance equitable outcomes. The model governance structure will be reviewing each hospital health equity plan using a guide that is that will be provided by CMS. And then participating hospitals and primary care practices must collect and report standardized self-reported patient demographic data to CMS. So this will be used for monitoring impacts on health disparities and patient outcomes. We know this is a pretty heavy lift for many of our providers. So CMS recognizes that and will be providing technical assistance related to this requirement. And then participant hospitals and participant primary care practices will also be required to screen patients and make referrals for health-related social needs related to housing, food, and transportation. Next slide. So the state is actively working on strategies to advance health equity today, but AHEAD provides an opportunity to really leverage and build upon our current efforts within the state. So as part of our development of the NOFO, we've really been focusing on coordinating with current activities and experts. So we've been meeting with the Health Equity Advisory Commission, the Vermont Department of Health, which works on the state health assessment, state health improvement, community engagement process. The board with the Act 167 community engagement activities, the AHS Health Information Technology and Board's data team, and Blueprint for Health. So we really intend to leverage the extensive information, data, and expertise of these entities to design the model governance structure and inform the work that I just spoke about on the last slide. We also really want to do a lot of work with these experts to ensure that the model is informed by diverse perspectives, including those populations experiencing health inequities. We'll need significant strategies in that area. Next slide. So I think the next piece is going to be focused on the cooperative agreement funding. As Pat had noted, states that are selected would receive this funding. You can go to the next slide. It is approximately $12 million total, distributed over the first 5 budget periods. The state applicants must submit budgets as part of the application to the model that include activities needed to successfully establish the model. So that could be things like recruiting primary care providers and hospitals, setting statewide total cost of care growth targets and primary care investment targets, building infrastructure and capacity for mental health and substance use disorder, and supporting Medicaid and commercial payer alignment across the model. CMS has provided examples of the uses of funds. So you'll see a number of activities here on the slide that would really support achievement of population health goals or those infrastructure to be successful. Next slide. I'll just actually also note on that piece that as we're developing the application, we'll really be considerate about what are those time-limited one-time investments that will support model implementation and transformation, because it's important to be considering sustainability, and we'll also be needing to submit a sustainability plan. Next slide. Great. So Pat spoke a little bit about this earlier, how Medicare waivers are supportive in ensuring we can support care delivery transformation under these models. So you've seen this slide before. We're just pointing this out again. So you can go to the next slide. So CMS has the authority to issue Medicare waivers to test innovative payment and service delivery models. They'll provide operational flexibility and help participating organizations succeed under the model and can support care delivery transformations. This is sort of the framework in which they decide what waivers would be available under each model. We'd expect to be seeing additional guidance from CMS on what waivers will be available under the AHEAD model. And we expect, based on some of the webinars we saw, that there will be substantial waivers under here, but it has not currently, we haven't currently seen that list yet within the notice of funding opportunity. So prior to seeing the NOFO come out, AHS in partnership with the Green Mountain Care Board convened a Medicare waiver technical advisory group through the healthcare reform work group structure. The group met last spring to discuss things like problems that newer revised waivers could help address, on the ground experiences with implementing waivers under our current model, and new waivers that are of interest. Our stakeholders really described a lot of operational challenges that have limited Medicare waiver uptake as currently implemented. Those are things like billing and contracting and attribution-based eligibility. So we've raised these concerns with CMMI and continue to advocate for opportunities to improve waiver implementation over the time period of the HEAD model. As Pat had noted before, this is 8 to 9 years. We hope to be able to make those more and more usable as time goes on. So next slide. So the technical advisory group identified and proposed to CMMI 24 waivers that could support care delivery reform goals. So they looked at proposed modifications to our current waivers and our current model, Medicare waivers that have been tested under other CMMI models or during the public health emergency, and then current waivers that we would like to be extended that we currently have benefited from under the current model. So examples of goals and related waivers are included on this slide. So some of the things we discussed and are part of those 24 activities or waivers that we've requested from CMMI are connecting Vermonters to the right care at the right place at the right time. So really 2 waivers that help accomplish that are the post-discharge home visit waiver and the skilled nursing facility 3-day rule waiver. A 3-day SNF rule waiver would allow a patient with a fall-related injury, this is an example, to access services such as skilled nursing facility care without having to meet that 3-day inpatient requirement. The next would be expand access to services at home. So examples are the home health homebound waiver and the care management home visit waiver. So that waiver would allow someone to receive in-home care to avoid ED utilization or hospitalization. Then improve care delivery at the end of life. So this would be a concurrent care for hospice beneficiaries waiver, and that would allow someone to continue sustaining curative treatment in addition to receiving the benefit of hospice care. And then the last one on this list is enhancing access to care, especially in rural areas, through optimal use of technology. And the area we've focused on here is expanded telehealth benefit enhancements. So these were available under the public health emergency and are currently extended by Congress, but those could end up not being available in a 2026 time period. So we're hoping those will be continued under this model or through other means. I think that's the end of our slides, but I think, Michelle, do you have additional slides to present?
I do. So I'm going to pass through the appendix slides here, and we can reference them during the question and answer period. So AHS team, just let me know which one I need to go back to, if any, when we get to board questions. So give me 1 second. Oh, that wasn't as bad as I thought. So hi again, everyone. Michelle Degree, Health Policy Project Director with the board. I am here to talk to you today briefly about the global payment model development section of this work. It'll be a really brief update from me today, just touching on a couple of things that have happened since your last presentation on this in November. That would have been delivered by Sarah Kinsler. You will more likely than not hear a lot more detail from GMCB staff in January and February on as we sort of continue this moving forward. So again, talking about Act 167, Sections 1 and 2, and developing the value-based payment models work where GMCB is currently the leader. So Act 167 predates the engagement with CMMI and a potential multi-state model, which ultimately became AHEAD, which Pat just walked us through in wonderful detail. Thank you, Pat. But that is focusing on new payment models, and we're specifically calling out hospital global budget development here. There's great alignment with the work that we've done with the 167, so we've been able to really connect these two work streams. I know Pat talked about other payment models, including primary care AHEAD, but again, I'm really just focusing on the work that we've done with hospital global budget development. You've seen this slide before, just talking about the reminder of who's included in the tag, the sort of makeup of that group and their charge. You'll see that meetings occur approximately every 3 weeks, and they began in January of this year, and our final meeting is currently scheduled for February 9th of 2024. We do not have a tag meeting scheduled in January at this moment. I also wanted to give an update on this slide where you can see that we have now successfully checked off all of the boxes. I think the last update you had, we were still outstanding in talking about program administration and evaluation and monitoring, and we covered that at our December meeting. So we've now kind of hit on all of these topics here. I'll go back one. Our January meeting, or February meeting, sorry, is the group is going to focus on a review of the state's global budget model, and then a comparison to what CMMI has proposed. That's sort of what you just heard with Pat, but we're going to walk through that with the tag members in February. So the goal, progress, and sort of future plans is to continue to build out that Medicare portion of the fee-for-service straw model, sort of starting with those key, the recommendations from the tag. It's required some pretty serious data and operations challenges. We know that we won't be able to meet all of the tag's recommendations, at least not in the first couple of years, due to sort of just technical feasibility, but hoping that we will get there. And then we're continuing to work on the commercial portion of that straw model with a date sort of to be determined in the future. And just a link on this slide as well that you can access all of the tag materials publicly on the board's website. Just to wrap up, I promised it would be quick. I just wanted to do an overview of the board's process. Again, AHS is leading the charge here on the AHEAD application and process. There will be a continuation of these monthly AHS and GMCB staff presentations through March, at which time the application for AHEAD is due on March 18th, as Pat listed. So public board presentations will continue to address concept areas and application approach, and we may bring in other staff as subject matter experts along the way. There is no board vote required on the AHEAD application, as the application itself is being led by the Agency of Human Services. Should the state enter into negotiations on a future agreement, staff will present on future decision points and state flexibilities at that time, and determine where and when to issue board votes on that matter after the application process. That's all I have for you all today. We can turn it back to you, Chair Foster, for questions.
Great, thank you. I will open up to any other board members for questions or comments they have for our friends at AHS or Ms. Degree.
I guess I'll jump in if that's okay. Thank you so much, everybody, for presenting. It's so helpful for us to get these updates. So much work I know is going on and behind the scenes to start to think about this particular model and whether it's right for Vermont. So can you go to slide 5, Pat? I think it's slide 5. This was the kind of the priorities of the state. Yeah. So one of the things that I'm interested in learning about and understanding is the transformation dollars. And I noticed on the slide, there wasn't a line item for making sure that the state had transformation dollars to help our, healthcare providers make this transformation from fee-for-service to value-based perspective, fixed payments and things like that. So, back in the day with the all-payer model, there was $200 million on the table for transformation, and that's probably at the peak and the cap. And there's probably ways to think about those dollars, and some were federal and some were state. But in my mind, that was a pot of money that was available for what we knew was going to be a challenging transformation for our providers to do. And so I'm wondering, and maybe that's not the right comparison, but in my head, that's a bit of a comparison number. And convince me if I'm wrong, if that's not the right number to think about comparing that model to this model. But then when I think about the $12 million, that's really, and looking at where those dollars are going, it's not really going to the providers. It's going to kind of move us, staffing at the state level or IT infrastructure or some of the examples. But it's much smaller amount of money, and it's not actually going out and as to directly help in transformation. So I just wanted to ask a little bit about that, whether that was a priority that was considered and not shared with CMMI, or it wasn't a priority, or just what you're thinking about the transformation dollars. And then I do have a question. I understand there's additional funding for the incentives for hospital participation, the 1%. I have a question about that, but just more thinking about the bigger bucket.
Sure. Thank you, Dr. Holmes. Is Chair Foster, is it okay if I go ahead and address that?
Absolutely, please. Yeah,
Okay.
thank you.
Okay. Yeah, the 200 million, that may not have, I know that was a number that was bandied about, but I'm not sure that was ever, fully available. But, in terms of, did we articulate the concerns that transformation would take significant resources? Yes. So this is probably not a comprehensive list of everything we spoke to. I think that, what CMS is thinking is that, the hospital, that transformation incentive is one piece. The cooperative agreement funding, yes, it's not a lot of funding, and it would probably be used for a multitude of things potentially. But, the transformation dollars for the hospitals, the predictability of, and the, non-reconciliation to, fee-for-service costs would allow hospitals flexibility in how they use their funding. So that's another source of support for transformation. And then in primary care, the enhanced primary care payment, I think, is seen by CMS as supportive of care transformation. In fact, they, pretty directly suggest that. Whether it's enough funding, I think, remains to be seen. And whether the flexibility is enough to encourage participation remains to be seen. I think they're really trying to build those transformation dollars into the hospital global payments and into those primary care payments as well.
Fair enough. I mean, I appreciate that. So let me ask you a little bit about that then. So I think it's on slide 16. That's where the incentives for hospital participation, year 1 and year 2, I think it was 1%.
Mm-hmm.
Yeah, so there's initial investment to support hospital transformation in the early years of the model. And I think what I heard you say is it's years 1 and 2, and it's 1% of the net patient revenue tied to Medicare traditional fee-for-service. Is that right?
Yes.
So, and so on that note, and also I think the enhanced primary care payments was $17 per member per beneficiary per month but it's also tied to traditional Medicare beneficiaries, right? So part of my concern a little bit is we've, back in 18 or so, it was less than 10% of Medicare beneficiaries were on Medicare Advantage, and now we're north of 30% of our Medicare beneficiaries on Medicare Advantage. So if trends continue, and I'm not saying that they are because I don't have any predictive modeling of what we anticipate Medicare Advantage penetration to be in 2026, 2027. But if it's continuing to increase, if they're going to tie the transformation dollars to traditional Medicare, right, and we have fewer and fewer on traditional Medicare, and if they're tying the $17 per member per month to traditional, only for traditional beneficiaries, I guess I'm just, again, I'm trying to understand how much money there really is going to be coming into the system for the things that we really care about, which is helping our providers transform care management, all of those things, if it's tied to traditional Medicare, and we know that's a declining proportion of our beneficiaries. So any thoughts on that?
Yes, a couple of points I want to make. That is the incentive payment that we're hearing for a CMS hospital global payment methodology. But Michelle, if you go to the next slide, you'll see, again, that shaded box states, and really the work of the Hospital Global Budget Technical Advisory Group over the past many months, states like Vermont would have the ability to propose a state-designed hospital global budget methodology. And so there may be an opportunity there to, they want a transformation incentive. Actually, Michelle, thank you for driving. If you go to the next slide as well, when you see that list of what CMS is planning to require in a state designed methodology, you can see that fifth bullet down talks about incentives to recruit and retain hospitals early into the model. And so they're saying similar to the transformation incentive adjustment, but it seems like there's some latitude there to possibly propose something different. And so that's an opportunity for sure. I want to also, so that, for hospitals, I think putting some thinking into how we can support that care transformation is going to be really important. For primary care, the payment, the enhanced primary care payment, we've tried to sort of crosswalk that with what practices currently get under the current model. So they get, blueprint payments if they participate with the blueprint. If they participate with the ACO, they get some population health management payments. If they participate with the ACO and also are an independent practice who participates in the comprehensive payment reform, the CPR program, they get payments. So, we've tried to compare that and understand that other payers, in fact, Medicare really at this point juncture doesn't contribute to a lot of that. They contribute a per member per month payment for the blueprint. I think it's about $2.15. Other payers pay more, including Medicaid. They don't participate in the hub and spoke program. They don't make payments they do make payments for community health team, core community health team services, and for the SASH program. But, there's some funding that's happening now on behalf of Medicare members that isn't actually coming from CMS. So, we have a number of payment streams that we would look to continue. Medicaid being the payer that tends to try new payment streams for new programs first, including for the current expansion program. But, putting that all together, it's not just Medicare paying for their beneficiaries currently. In fact, they don't pay for everything that their beneficiaries get currently. But all those funds are going to be important. The good news is, in some ways, we already have some of the transformation underway. And again, I'm thinking of the blueprint. When I look at that primary care transformation, I think Vermont is a state that's in good shape there. So some of that's already underway. We obviously want to keep improving and building on things, but our providers are doing a lot in that space. And, I think that's somewhat true for hospitals as well. So just trying to maximize support for those efforts is going to be really important. That's the whole point of this. Changing the way we pay for care isn't the end goal. It's doing so in a way that supports providers and care transformation.
I
So
appreciate
thank
that.
you.
No, and thank you for that. And actually, I'm glad this slide is up because that last bullet point struck me a little bit. And I'm just wondering how, what the response has been, I guess, from critical access hospitals to that criteria that payments cannot be fully reconciled back to costs or fee for service.
Yeah,
for
I
critical
don't want
access
to
hospitals.
speak for them and won't try to do so, but other than to say, yes, there's, that's a sea change from how they receive funding now. I think a lot of it depends on what the dollars look like as to whether it's supportive of critical access hospitals. And we're doing a lot of work with the global budget tag right now, and with your staff and your contractor to really try and figure out what the numbers look like. I think that's going to be really important. I think critical access hospitals are interested and very cautious here.
Yeah, thank you. And I guess my maybe only one or two other questions. One was on the accountabilities that we're thinking about, and I guess this would be slide 24, maybe. I took down this note, but is that right? Accountabilities. I think that's 23. There we go. Yeah, this is great, and this is really helpful. And one of the areas that I'm interested in particular is and I know you don't have the answer to this. I'm just planting the seed right now. Is accountabilities for access and ensuring that access is not compromised if we do this model. How do we measure access appropriately? And then how do we track that access is not being compromised by the change in the payment towards global payments and things like that? So I just want to put a pin in that to say, as we think about state accountabilities, that's one that's really important to me. I'm just Jessica, but that's the one I'm going to be looking at to think about. And I guess my final question really is, given that there's 3 cohorts, and I'm just wondering how you all have thought about being the first out of the gate and applying in cohort 1 versus waiting, seeing how the model plays out in other states and being in a later cohort. So just wondering where your thoughts are on applications for each cohort.
Sure. I'll speak to both points if that's okay. Your colleague, Robin Lunge, as a co-chair of the Hospital Global Budget TAG, has been very articulate and passionate about the access issue as well. I want to note that, this is what we're seeing in the notice of funding opportunity and from CMS, but clearly, a key element will be some monitoring measures. And those will and should include access measures as well. So that, we'll be wanting to monitor if we, again, if we get accepted, if we move forward, we'll want to, definitely monitor what the impacts are on access and other key areas. And the health equity measurement provides an opportunity to focus on access. In terms of the timing of when to apply, a couple of things. There does seem to be quite a bit of interest from other states in terms of the model, both on, for a whole state, but also we're hearing, rumblings about sub-state regions applying as well. And there is that limitation to 8 states. So, with, potentially 5 of the 8 states happening in the first 2 cohorts. So I think that's one consideration. Another is that our current model, could be extended through 2025 if we can come to agreement, but, not sounding at all like it would extend beyond that. And so we, having that discontinuity could cause a lot of problems in terms of the Blueprint and SASH funding, the sort of recognition of our prior savings, and a potential reversion to fee for service. So there is some concern about lapsing, and since cohort 1 is the cohort that would start in January of 2026, that seems appealing. I also think, as daunting as all this is, and, you said questions, there are so many questions and we don't have answers to all of them. And that's really hard for our partners in the state, for you all who are, ultimately decision makers here. But it's daunting as it is. Vermont may be as ready as, most other states. I mean, Maryland has a lot of experience with hospital global budgets, obviously. There are others Rhode Island has experience with primary care investment. There's a lot of experienced states out there. We're kind of one of them. So, in terms of readiness, we are probably in the top 3 to 5. So
Great. Thank you so much, Pat. I appreciate that. And thank you, Robin, for being passionate about access.
This is Tom. Hi, Pat and Wendy, and thank you, Michelle, for joining us again. And I read through the NOFO, skimmed it. It's a lot, but what I tried to do was reflect on the first all payment model that we've had, try to understand what I was reading, and then pretend that I was reviewing proposals. Something I have a little bit of experience with, reviewing proposals for federal funding. Not a ton. I'm not somebody that does it all the time, but I've done a little bit. And a couple things come to mind with this and Vermont. If I was reviewing a proposal, I'd want to know more specifically about recruitment, because we had difficulty with recruitment in the first iteration. And it seems like it could be difficult to recruit providers and healthcare systems to alternative payment models. And my sense is that what healthcare delivery systems look for is help, right? Some situation that will help them meet the objectives of this. And that's not just money, right? I could read a NOFO that was looking for individuals to explore outer space. And there could be, per click payments to me for learning about exploring outer space. but I don't know really how to do that. I can't get myself off the ground. And if I'm a little bit financially focused, I might say, well, there's money right here. They'll pay me to just look around. But if I'm more long-term focused, I'd say I'm never going to be able to meet that objective. I don't have the skills or the time to do that. So I'm not going to join. And so thinking about what services can be provided from day one to organizations that you hope to recruit, I think could be really helpful. And one of the first things that comes to mind is equity, right? As a provider organization, you have to be able to find where you're not equitable. That you need ready access to data, and you need to be able to stratify by age, gender, race, social determinants, some measure of income, some measure of education, some information about transportation. How will you know where you're not equitable? And then the places that are going to need the most help are the smallest ones with the least IT budgets, the least analytic budget. So it's going to take quite a bit of money, not equally distributed across the state, but equitably distributed. So the provider systems that are the worst off now get the most to come up to snuff. And that makes sense because oftentimes those providers are in places where the patients who are being treated the least equitably reside. But really, I'd be reading applications, saying, how are they going to recruit? So I don't want to say yes to a state that can't recruit enough. And how specifically are they thinking about what services they'll bring so that delivery systems join? And then how are those delivery systems not just giving per member per month, which is kind of equal, that's right, the same number in per member per month in different places, but how are they going to make that distribution of dollars equitable so the places that are struggling the most receive the most?
Thank you.
Yeah,
There are, oh, sorry.
No, please, go right ahead.
There are a number of really critical points that you raise, and I'll try and respond to as many of those as I can. First, in terms of the payments, CMS has made it clear that in this model, they're looking to adjust whether it's a hospital global payment or a primary care payment. They're looking to adjust those payments in a way that's reflective of the populations that are being served by those hospitals or practices. So that, that will at least begin to address some of that equitable distribution of funding. In terms of the, you need more than just giving dollars to organizations. The organizations need help. I think back again, I worked for the Blueprint a number of years ago when it was rolling out statewide. And I think back to sort of a basic tenet of that model, which was that it wasn't and hasn't been just give more money to practices, but there were some really significant foundational underpinnings to that model. One was a payment model. Another was data, support with data and analytics. Another was really establishing a learning health system where practices could and community health team administrative entities could learn from each other. And those elements persist to this day. There's a group of quality improvement facilitators in that model that provide support to practices that, want to look at their data or need to, work on some workflows or need to look at NCQA recognition. There's there's quite a bit of support there. There's the development of payment models that support things like the hub and spoke or the pregnancy intention initiative or the core services that are provided by community health teams and practices. And it was never just about providing dollars. And you're absolutely right. And the point there is that, again, payment changes are a means to an end, but they're not the end, and they're not the only thing that needs to happen in order to transform care. We've said it quite a bit through our discussions on this model, but changing how you pay doesn't mean that organically care delivery will just happen. There's got to be intentionality to it. There's got to be support of the type that you're mentioning here. And that's all going to be important for recruiting providers to participate in this model. So thank you.
Well, thank you, Pat. I think you're exactly right. And I think, again, just trying to pretend to be a reviewer of these applications, I'd be really interested in seeing very specific plans to help recruiters. We know that the highest cost beneficiaries that have the most difficulty with managing chronic conditions are patients that have chronic conditions like poorly controlled diabetes plus a comorbid mood disorder, anxiety or depression. And if I were reviewing and somebody had written that the first thing that we are going to do is promise that we'll go into organizations, be able to tell them what proportion of their patients have diabetes with an A1C level greater than 9 and comorbid anxiety or depression, whatever that percentage is, then help you find them, right? And be able to stratify that by race and gender and income, all the social determinants. Just starting with one thing like that, very specifically, I think that would be more enticing to me as a reviewer than we're going to give every practice, we're going to distribute money to every practice. There's being really specific about that and tying the recruitment to helping them meet the equitability goals. The other piece that has come to mind when I was looking through it is enforcement. If a state or delivery systems are not meeting goals, what will be done? What role will regulators in a state have to make adjustments? If a delivery system is not meeting goals or failing to meet targets, where does the regulator act? On the all-payer model entity, whatever that may be, on the agreement, or on the delivery system itself? And finally, I'd want to see in an application some forethought about potential unintended consequences and how they'll be dealt with. With the all-payer model, the first one so heavily centered around accountable care organizations, we didn't know in 2008 to 2010 that by incentivizing care coordination and integration, that we would get so much consolidation across the country. And that's led to unintended consequences of rapid growth in prices, particularly affecting commercial ratepayers. And so some thinking about what could be unintended consequences with this model, and what are some stopgap measures? How would we stop it if the unintended consequences are too big or too much? I think that those things would be really important to me if I were reviewing applications.
And I'll just note that again, focus of our discussions, with the global budget tag, and in other venues has been on really monitoring for those unintended consequences. And in terms of enforcement, the most fundamental enforcement from the federal government is if we don't get 10% of Medicare, traditional Medicare patient revenue into under global budgets by year one, there's not an agreement. And then there's that 30% goal by year four. And then similar with the commercial payers. And there's, we've had discussions around, whether it's a voluntary model, a mandatory model, and decisions haven't been made there, and they don't need to be made for the application, but they're definitely things that should be top of mind for sure. And then monitoring not only on the monitoring and framework, but looking at evaluations as they become available, and then looking at those measures both at the statewide level and the provider level that we're looking at actually on these slides right here. Looking at the performance on those measures is going to be key. Thank you.
Thanks again, and coming and sharing this with us, and I look forward to learning more as it continues to develop.
Great, thank you.
I'll jump in. Thanks, Pat and Wendy, and all the comments thus far have been quite interesting. I think I'm just going to pick up a little bit on where Tom left off and highlight something that Jess had said as well. And I think that we all sort of share this concern from how the comments are being and questions are being phrased. But it's really regarding Jess's comments on access, which is if fee for service is a system and the sort of predictable downside of fee for service is increasing volume and subsequent unnecessary care, I think the predictable downside of a global budget or a capitation model is the opposite. It's we are incentivizing providers to reduce care, and I think the hope is that we are reducing the unnecessary and low value care. But I think that the monitoring that we need to have in place, and I think it probably needs to be fairly sophisticated, is to avoid reducing valuable care, and especially high cost care, so that it would make sense if you are an organization and you're getting trouble with your budget near the end of the year, that the first thing to do is to get rid of the high cost components and make your system, so your organization stays in business, so your hospital stays afloat. And so we want to be very careful that we don't incentivize reduction in necessary care while we are successfully reducing unnecessary care. And I'm not sure if I've heard throughout all that I've read around the country and discussions, clear safeguards within that. I think that's something that we just need to think about on how to build that in. But maybe that's more of a comment than a question, because I have like a burning question, which I just need to understand the basic concept of this is, so the AHEAD model is a Medicare model. This only refers to Medicare patients. So the budget slide and how the budgets are built, this is specifically for the Medicare component of the budget. And it sounds like we could use, in a global budget model, we could use a different methodology to construct the commercial budget, for instance. Does that seem fair to say?
I did a pretty bad job of actually articulating that, so I'm glad that you asked the question. So from moment one, the expectation is that Medicaid will be offering a global payment program as well for hospitals, and CMS will be expecting some level of alignment between the Medicaid Global Payments Program and the Medicare version. So that, Medicaid has to be in, and our colleagues at the Department of Vermont Health Access are really building on what they have learned and the expertise they've developed in the current model, and are looking at trying to roll out a global payments program. So there may be some flexibility, but there's going to be a pretty good expectation of alignment as well. And I would imagine the same would be the case with commercial, but we haven't seen a lot of detail from CMS on that, and they have less latitude to influence that perhaps, but certainly for Medicaid, that's the expectation. And I just want to note that I couldn't agree with you more on ensuring that we monitor appropriately for, you're right, there's the fee for service incentive versus a global payment incentive. And you're absolutely right that, good monitoring on, really strong, robust monitoring of what's happening with access and utilization is going to be critical.
Thanks. Yeah. So the pot of money that would be the Medicare portion of the state's global payment budget AHEAD program, would that be, say, if say the scenario where 25% of the NPR in the state were in a, say 30%, say we're year 4, 30% is where we end up. Maybe we have more, it's not going to work if we don't have less, if we have less. So say 30% is the Medicare component of that global budget that the state is administering made up of that number, that is that historical 30% revenue. I guess it's year 4, so it's adjusted a little bit, but roughly that, is that the pot essentially?
Yeah, I think what they're going to do, and I would welcome phoning any friends who might want to jump in here. But I think when they're looking at global budgets, what they're going to look at is sort of a baseline year, and then they'll make adjustments to that annually. So I think
how about hypothetically the first year, then we have 30% in, that's that 30% NPR would be the budget. Okay. So then
I think they're saying that, like, for year 1, you have to have at least 10% of the Medicare, fee for service patient revenue. And now I guess I'm not entirely sure, like as that changes, does the target change, or will the 30% in year 4 be 30% of what that baseline is? I guess I hadn't really thought about what that denominator looks like. So
okay, but say theoretically we have hospitals in Vermont that sign up such that 30% of the Medicare NPR is under a global budget, and then they get like a 1% bump because it's in the first year, and we get some portion of $12 million in that year as well. is the $17 per patient per month for primary care come out of that amount, or is there an additional amount on top of that goes to primary care?
It's an additional amount.
Okay,
It's an
so if
additive payment. Yeah.
so say if in year one, instead of 30%, we have 10% of hospitals join in that bare minimum, but then all of our FQHCs want to join in the primary care model. Are they able to do that and still get that $17
Mhm.
per? So okay,
Yeah, there's no minimum requirement for primary care participation in the model. So unlike the hospitals where they're saying that 10% of that patient revenue for inpatient and outpatient services has to be under a global budget by year one, 30% by year four. For primary care, there is no minimum number of primary care practices that have to participate in order for us to, if I feel like I keep having to say if we're selected and decide to move forward with the model. However, the fact that the state has accountability for increasing primary care investment, not having, participation is clearly going to impact, because, that additive payment is an increased investment. It's clearly going to impact if we don't, not only from, the point of view of, do we meet that statewide target, but from a care transformation point of view as well.
so could no hospitals sign up and a whole lot of primary care practices sign up?
If no hospitals signed up, we would not be in a model because there has to be at least that 10%. Now, the way our hospitals are, depending on what hospitals you're looking at, one hospital could get us there. There's a couple of hospitals that represent over 10% of the Medicare fee-for-service amounts. It could be, 2 or 3 smaller hospitals. But if we have no hospitals that sign up for the model, there would not be a path forward, because you have to meet that, a state has to meet that 10% requirement in year one.
But theoretically, we could just sort of as an option, that 10% of the hospitals, NPR, maybe a few small hospitals sign up. All of the rest of the primary care in the state could sign up and potentially get $204 per patient per year for Medicare patients, sorry, in a prospective payment.
Not quite all, because if a hospital doesn't
Non-hospital
sign
owned.
up,
Yep.
unless it's a rural health clinic.
Right, right.
So,
Okay.
yeah.
So that then,
Could I just add one thing
yeah,
to that hypothetical? I would say until there's a measurement of the Medicare savings target and we blow it potentially, and then I think there will be some mechanism or vehicle for corrective action or whatever. Because remember, their model assumes that that if we're blowing total cost of care for Medicare as a state now, not just for the participating providers, but as a Medicare as a whole, that the adjustment for that comes out of the hospital global budget. So if you have too few hospitals and too much primary care, at some point, you're not going to be able potentially, right, to meet the Medicare savings target. And then, we have to see what is in the, what they're offering in terms of the enforcement there. But there's either corrective, in the current agreement, there would be either corrective action or a triggering event, which could lead to, withdrawal from the model or kicking us out of the model. So that's the other component to think about, is that these statewide accountability targets are meant to be the overall sort of safety valves for Medicare to ensure they have control vis-a-vis the state of too much spending, for example.
okay. So thanks for that. So if we have 10% of the NPR in, do we have a statewide target though? so it's not all on that hospital, it's on the statewide target?
It's both. The state has the total cost of care accountability, and then we anticipate that hospitals would have some accountability for total cost of care within their area as well.
Okay.
And
So one thing
I just want to note that total cost of care, whereas what CMS is putting forth is that the hospital global payments will be in their version of the model from inpatient and outpatient services to start. When they're looking at total cost of care accountability, they are looking at your Medicare Part A and Part B type services. So it would include not just hospital facility, inpatient and outpatient care, but it would also include professional services and other those sort of Part B type services.
Okay. So one thing that I think I gleaned from this pass through this presentation, which I've had several passes through this presentation,
you
which
could
I think
probably give it, but yes,
not quite, but that the in the CMS slide talking about, this is sort of something that's bothered me in the past, but I think I understand it better, is that talking about building hospital budgets from the bottom up, but based on prior NPR, which sort of always, those two things seem to be in conflict with me. But since we're specifically talking about Medicare here and not talking about commercial, it's a less of an issue for me because, and part of that is I'm just sort of explaining sort of my interpretation of the slide. It was misinterpreted in the past because I was expanding this to commercial as well, where if we built a hospital budget based on prior experience in commercial, Medicare equalizes the payments, where commercial, the payments are quite different. So I would imagine a hospital that's had high commercial reimbursement might be one that wants to sign up for it, but a hospital that's had low commercial reimbursements, I don't know if I want to sign up for that. Maybe I could figure out how to increase my commercial reimbursement before signing up for that. So to me, I was sort of reassured that this methodology is specific only to the Medicare component of the global budget.
right.
I don't know if you want to say anything about that. But,
Yeah.
and the only other thing I wanted to ask about today is the Blueprint SASH funding through this. Has CMMI committed to or discussed funding the Blueprint and SASH programs through the AHEAD model, or is that still an area of negotiation?
They actually have. They have said, and this is a win for the state, but they have said that they would continue to provide funding for the Blueprint and SASH. Now they think that that's, they're basically saying that the $17 average PM that would encompass Medicare share of the patient-centered medical home payments, which I believe is about $2.15 PM. But they're saying that they would continue to provide a similar level of funding for Blueprint and SASH. There's still some questions about how that would flow, who would receive the funding, what would happen if in a health service area the hospital wasn't participating. But the indications we've gotten is that there's some flexibility there, that the state could think about how best to use those dollars. The payment mechanism is going to matter, and that's still uncertain. But yes,
So-
and that is a potential real benefit of this model.
So when we're adding it up, it would be the hospital's global budget, the primary care PBPM, the
Mhm.
Blueprint and SASH funds, and they all have to sit under that total cost of care cap.
We believe, yes, they do.
And then
Yeah.
if there's room there, is there a shared savings that comes back in addition, or is that's not Robin saying no? Okay. I didn't.
No, there's
I didn't-
not really a shared savings component. I think where the question would be is if we as a state, and some of this, quite frankly, we should is I don't want to go into this too much detail in open session because it starts to get into negotiation postures, but there are ways that there are some things that the state might be able to negotiate in thinking about, if there were quote unquote room under the Medicare savings target, there might be ways to creatively think about drawing down those dollars. But I think saying more than that is potentially harmful for us in a future negotiation, should CMS choose to listen to our meeting at a future date, which may or may not happen. But I think part of what we can do maybe next month, if that is acceptable to others, is, think about how we could maybe talk about that in an executive session or something like that. Pat, I don't know if you agree or disagree, but I just wanted to throw that.
I do agree. Yes.
All right. Thank you. We could probably have a conversation about this for days on end, but I think I'll lull everyone else in the world to sleep who's involved in this. So thank you so much. And
thank you. And thanks for your involvement in the work.
Robin, did you have any questions or comments?
No, I spend a lot of time with Pat, so I get to ask her my questions and give her my comments in real time, but thank you.
I'm going to turn my camera off just because my bandwidth is getting a little dicey. Just a couple questions, and thank you for the presentation. Early on, there was a couple references to continued recognition of Vermont as a low-cost state, and that our baseline calculations would recognize the past Medicare savings. And I was wondering if it's possible to expand on what you mean by recognition.
Yeah, I mean, I can give an example there. It appears that when CMS is looking at how they calculate total cost of care, for example, it appears that they're going to want to see it. Our current model has a target that has a savings component in it. So, a reduction in spending over what would be projected for Medicare. And so it appears that what CMMI is thinking and CMS are thinking is that a savings target might look different for a lower cost state than for a high cost state, simply because there's more opportunity to save if you're a high cost state. If you're already low cost, you're probably doing some things right. So it's that type of thing that we could potentially see some tailoring for states that are low cost.
In terms of the measures, the monitoring measures, is slide 24 reference the CMS national quality programs? Yeah, in the middle there. Is that the universe from which the hospital level payment model measures can be pulled from, or can we create our own?
Yeah, they're saying actually that there might be some latitude to to select different measures. I don't know that they'd want to see homegrown measures, but there might be some latitude to select measures as long as they're in the same domains and they're similar types of measures. So I don't want to overblow what the flexibility might be, but it did sound like they might be open to some alternative suggestions if states feel that would be helpful.
Oh, and can I weigh in for a quick second on this slide? Because I was confused about this slide in a prior presentation. And Pat, correct me if I'm wrong, but these are hospital level measures that the hospitals have with that we have with the federal government, not as a not if we want to have our state measurement system to regulate this plan at the state level. Is that correct?
Yeah, I mean, what they're expecting from hospitals is that they continue, there's several national quality programs for hospitals. And what they're really expecting there is that hospitals will continue to report on those measures. But then when they look, so that's sort of the measurement construct for hospitals. When they look at primary care and statewide measurement, that's where they're suggesting a couple of measures. And that those, there's more detail on those measures in the appendix. I was just trying to page through and find the slides there, but there's a slide that talks about statewide accountability targets. And they're, yep, yeah. So these are the measures that they're saying for statewide accountability. You have to pick one, states would have to pick one from each of those core domains. And in some cases, there is only one, but select one measure in each of those areas, and then at least one measure, and this is all at least one measure from that whole list of optional measures. Then if you go to the next slide, that's where it talks about, thank you so much, Michelle. That's where it talks about the, what hospitals have to report on. And so our PPS hospitals have a number of areas that they report on related to inpatient quality, outpatient quality, value-based purchasing, readmissions reduction, and so forth. So hospital acquired conditions. So they're still going to have to report on those. But the idea is that, what you can see there is that the state designed, if a state was to go with a state designed methodology, there could be some adjustments there. It's got to be similar. They want to see, at least the level of accountability and performance, but there might be some flexibility there. It is kind of confusing though.
Yeah, I think what's had been confusing to me in the past, quite frankly, and I have to always go back in my head and say, who is being measured and for what purpose? So the statewide measures are the state accountability to the federal government. These ones that we were just on, the hospital ones, impact the hospital payment. The primary care ones impact the primary care payment. And then, for example, the monitoring framework is meant to more broadly at the state level. So not between the state and the federal government, where the federal government has enforcement against the state, but at the state level to make sure that we are comfortable that what's actually occurring in the provider community is heading in the right direction, right? And then I think the next question, which kind of goes back to Tom's earlier question, is what do you do with that monitoring framework? Is it connected, for example, to the hospital budget regulatory process or not? Like those are all state questions, which the state will have to make a decision on outside of the agreement. Although obviously it's all interlayered.
Thank you. That's really very well and much more clearly said, Robin. And so you can see here that for hospitals, there's a difference between critical access hospitals. Their measure set will be based on, their existing measures. The PPS hospitals have their measures. PPS hospitals could potentially be an upside or a downside adjustment based on their performance, whereas you can see here that critical access hospitals, it'll be upside only. Again, that effort to bring, to recruit and bring those safety net providers into the model. But there's a lot here in this particular accountability component, both at the statewide level and at the provider level. And so it definitely bears additional discussion.
Have the measures to check on access been utilized before such that we have confidence that they'll adequately work?
You mean in the monitoring set, Chair Foster?
Yeah.
Yeah, well, I mean, I think we look at, and we don't really have those outlined here. That's been part more of a discussion with the hospital global budget tag group. But there's some, certainly some utilization measures that are pretty standard that you'd want to take a look at and make sure that there's not concerning fluctuations in utilization. There are some, NCQA HEDIS measures that talk about people accessing everything from, primary care services, well visits, mental health and substance use disorder treatment. So there are some standard measures out there that really speak to whether people are accessing care or not, that can likely be drawn upon to really see if there are some trends and some of those unintended consequences that Member Walsh mentioned earlier. So there are measures. It's a matter of selecting which ones and whether they are, whether there are gaps there.
Yeah, it seems like the quality of the measures really dictates the success of the program in a big way.
Mm-hmm.
So just having some confidence that they've been pressure tested.
Oh yeah, yeah.
Work,
these are national
really...
measures. Yeah, I mean, some people know I have some. I would never call myself an expert, but have some experience with performance measurement from past things, and home growing measures can be a dicey business because these are national measures that have been validated and tested and so forth. It's not that there's never a place for homegrown measures, but organizations spend years specifying and testing these measures, and like you said, road testing them.
And then the adjustments that would be made to a hospital global budget, either for performance or service line changes or whatever it might be, are those done by the regulator, the care board, or are those done elsewhere?
So do you want me to jump in?
Yeah, please do.
So I think that's an undecided design component currently. In other states, like for example, in Maryland, the adjustments are done by the Maryland entity that does the hospital global budgets there. In Pennsylvania, the adjustments are done between there's a centralized entity, but the payer and the provider kind of have more negotiation around what those look like and how those get measured. So it's been done in different ways. I think we as a state will need to determine what we think is the right way to operationalize those things.
So if there's, I guess, when and how do we do that?
So I think the when, I think, is tied to probably decisions about whether or not to move ahead with a head on the Medicare side, and whether the state does a state methodology or a federal methodology. If we go with the Medicare methodology, then Medicare obviously would be doing that, not the state. If we go with the state methodology, I think, that's the piece that we'd have to think about. That The how, I think, could happen a number of different ways. So it could be legislative, it could be executive order, it could be, built into the hospital budget process. So, that will, I don't think, maybe Pat has a particular idea of how she was thinking we would do that. I don't think we're quite there yet. We'd have to have it in place for 2026. So there is some time.
Yeah, I will say that our focus right now is squarely on the application and what's required there, but really trying to keep an eye towards some of these other decisions that would need to be made at varying points. Were we to be selected, were we to agree to move forward if selected, there's a number of touch points along the way that we would, that we have our eye on, but right now the focus is really on what's required in that application.
And in terms of potential unintended consequences, which I'm sure there's so many that are really hard to even think of or conceive of at this stage, but if some of the money is from hospitals to support the primary care payments, potentially, depending on how it sugars off, and there is this bolus of money to primary care, do we anticipate and do we desire for, does that incentivize primary care to be consolidated in hospital systems more so?
I don't know that it necessarily would incentivize that. The payments are available to all practice types, and in fact, they have made it very clear that their goal is that this will be available to all practice types. I think in some of their other models, maybe FQHCs and rural health clinics have not been included. There's no requirement that a practice be of a certain size to take advantage of this program. So I'm not sure that it would incentivize that type of consolidation. And in fact, as noted before, if a hospital doesn't participate, non-rural health clinic hospital-owned practices can't participate. But it's worth keeping an eye on to see, is this supportive of different practice types and ownership models.
I don't think I had any other questions at this point, but thank you.
Thank you.
Yeah, I'll turn to healthcare advocate.
I was just thinking, and I know it's been brought up by several board members, but the issue of access, and I'm thinking there's, this broad level of access. So comparing like fee for service versus prospective payments, but there's also this question of access for whom, right? So a family at 500 FPL and who has ESI, it's very different than a family at 200 FPL, right? And so I'm thinking, Pat, that perhaps this question, this issue of access for whom could fit within the equity plan, which I know is a big part of the AHEAD model. And I'm kind of thinking about you cranking out this application. I also think, reflecting back on the APM, I think there's very little talk about patients and how this is framed. And perhaps that's intentional and understandable, but I think one of the frustrations in this model is, from a consumer perspective, is we talk about paying for providers and we talk about paying for hospitals, but there's a radical mutual dependency, right? Consumers need providers, providers need consumers, right? And, there is this sense that moving forward, it's not enough, in my opinion, to say at some unknown time in the future, some benefit will accrue to you, right? We know the benefit now for hospitals or for providers, but it's very amorphous when it comes to consumers. And this isn't to say we should have perfect knowledge moving forward, but we should at least hypothesize what we think of will happen. And then we can iterate over what we're actually seeing to see if we need to make adjustments to try to better the system. So that's all I have. Thank you so much.
Thank you.
Okay, I'll open up to any public comment. Great. Hearing none, I thank you again, Ms. Trafton and Ms. Jones, and I appreciate you coming in. And we will take a 5-minute break and then try and wrap up for the day. So we'll see you at 3:15.
Thank you all.
Thank you, Pat. Thank you, Wendy.
Not sure if Tom is back and if Kate is here. Kate, are you here? There's Tom.
I am
All right.
here.
Nice to see you. All right, we'll resume. Kate O'Neill, our Director of Analytics at the Care Board, will walk us through the HIE strategic plan and connectivity criteria, and we have a potential vote notice. And I'm sorry, we're quite a bit over on time so far, but take it away, Kate.
That's quite all right. I'm pulling up my slides, so you should be able to see them here. So yeah, good afternoon. I am Kate O'Neill, Director of Health Systems Data Analytics here at the board, and I'm presenting the staff review of the 2023 update to the HIE plan and the 2024 connectivity criteria. So just by way of process reminder, quick timeline, on November 1st, AHS submitted the HIE plan and connectivity criteria to the Green Mountain Care Board. At the November 15th board meeting, AHS and Vital presented the HIE plan and connectivity criteria. And during discussion, board members made requests for changes to the HIE plan. So as follow-up to those requests, on November 30th, AHS resubmitted the HIE plan, which is posted to our website and part of the materials for today. Throughout November and up through December 4th, we had opened a special public comment period, and now here we are today to provide a recommendation to the board on the plan. So I'm just going to start with the recommendations, and then I'll share a little bit of information to serve as the basis for these recommendations. But we recommend that the board approve the HIE Strategic Plan 2023 update as modified and resubmitted by AHS on November 30th, and recommend approval of the connectivity criteria for 2024, which is included in the strategic plan. So I'll do a review of the HIE plan first, and then follow up with the connectivity criteria review. So to support the board's review of the HIE plan, we proposed 4 review principles. We talked about that at that November 15th meeting, but I'm going to go through each one here. So the principles were developed in 2018, and we have used these questions or these principles every year since. So in summary, is the HIE plan in alignment with statute, whether the plan meets the goals of recent relevant legislation, and whether the HIE plan incorporates national best practice and stakeholder input. So we use these 4 criteria to review and analyze the plan. So the first is the HIE plan consistent with the HIT plan requirements of 18 VSA 9351? Now, this is the statute that outlines a variety of features that the HIE plan must address or include. And on this slide here, we list those required components, and we think this year's submission addresses these requirements, at least in some way, as we have highlighted on the right. I won't go through all of this here, but we do think that there is at least in some way, each one of these components is addressed. The second criteria is the HIE plan consistent with principles for healthcare reform in 18 VSA 9351, and will it help to achieve the state's health reform goals? We think yes, and the plan broadly aligns in a variety of ways with the principles for healthcare reform, and the Vermont Health Information Exchange goals do support improvements in healthcare delivery, outcomes, enriched healthcare data collection and analysis. The third criteria that we look at is the HIE plan consistent with other relevant legislation? Yes, we think. Recommendations for the Vermont Department of Health, Public Health Data, and HIE integration will be developed, and it's described in the plan. And that will include collaborative prioritization, plans for implementation, the development of appropriate data governance. And while not all of the recommendations in the plan would be implemented in the upcoming year, AHS expects that progress towards leveraging investments to bring public health into the unified health data space will happen over time. And also, the plan includes a recommendation for a more sustainable and patient-focused approach to integrating timely claims data in the HIE. And that includes work currently underway to integrate Medicaid claims data into the unified health data space, with an interest in expanding that out to include Medicare and commercial payer claims data over the coming years. So these two areas are responsive to and consistent with Section 4 of Act 167 of 2022, which is the most recent relevant legislation. And then the fourth question is, does the HIE plan incorporate national best practice and expertise, as well as feedback from Vermonters, including key HIE constituents, healthcare providers, and individuals? And we say yes, that in terms of national best practice, there are plans for building on interoperability related to connecting Medicaid providers with care coordination or referral tools, and to be connected to the Vermont Health Information Exchange. Additionally, national best practice around health data utilities focuses on interoperability with unified governance of health data, coordinated use standards, developing interoperability. These are all addressed in some way in the plan. And in terms of the connectivity criteria, which I'll talk about in just a minute, the connectivity criteria included in this plan is also based on national standards. So for stakeholders, stakeholders are now included in the HIE Steering Committee, as well as the Data Governance Council and the Data Integration Working Group. So the stakeholder voice is incorporated. So those were the four criteria that we looked at that form our recommendation to approve the HIE plan. I will say that we had that special public comment period, but we did not receive any written public comment related to the 2023 update to the HIE plan. Okay, moving on to the connectivity criteria. Here, we use two criteria for the board's annual review. We did not note any concerns with connectivity criteria as presented to you and in the plan for 2023. But the first question is, are the proposed connectivity criteria in alignment with HIE plan goals, and will they support implementation of the HIE plan and achievement of the state's health reform goals? Yes, this year's connectivity criteria remain aligned with the HIE plan goals and structure, and they're designed to support increased availability of high quality data. And then the second question is a question around whether the criteria are sufficiently clear to be operationalized by VITAL, the state of Vermont, and healthcare provider organizations. Yes, these criteria were developed to expand providers' ability to submit and receive data from the VHI. So as a reminder, the HIE plan statute in section 9351 states the requirements that the HIE plan must address or include in there. They're here, that it has to be revised annually. That's what's happening right now, and updated comprehensively every 5 years, which that occurred last year. And then including implementation of integrated electronic health information infrastructure and standards and protocols. The connectivity criteria is for providers connecting to the Vermont Health Information Exchange, and VITAL is required to present criteria for approval annually before March 1st, but for a number of years now, we've been reviewing the criteria in conjunction with the HIE plan review. So that they presented at the November 15th board meeting, and today the criteria, the connectivity criteria before you for vote. Just as a reminder, 18 VSA 9351 requires the Green Mountain Care Board to approve, reject, or request modifications to the plan within 45 days following submission. And so that's why we're here today at this late hour. And then also the board is required to review and approve the HIE plan to ensure that the necessary infrastructure is in place, and reviewing and approving the connectivity criteria for healthcare providers to maintain connectivity or to create connectivity into the exchange. So this is the last slide where we recommend that the board approve the 2023 HIE plan and the connectivity criteria for 2024. Here's suggested language for you, and I'll just leave it there and turn it back over to you, Chair Foster.
Thank you. Any board member questions or comments?
Just thanks for all the work on this. I know these are shorter than they used to be, but quite long documents to work through and discuss. So thank you.
Okay, is there a motion?
I'll move we approve the HIE Strategic Plan 2023 update as modified and resubmitted by AHS on November 30th, 2023.
I'll second.
Any additional board discussion on the motion? Any comment from the healthcare advocate?
Just really quick. AHS, we feel like meaningfully addressed our concerns that we voiced to them prior to their November 1st submission about ingesting VCures and also the utility of claims data in a clinical setting. We do support the approval of the modified and resubmitted agreement, and I would be also remiss not to publicly say, I think Kate is being added to the Data Governance Council, and she brings a tremendous amount of expertise, and we are all exceedingly lucky that she is serving on it and that she is a public servant. Thank you.
Thank you.
Second.
I don't think we even need a vote on that one. Any public comment on the motion made by Member Lunge? Great. All those in favor say aye.
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 Aye. And the motion carries.
So I will now move we approve the connectivity criteria for 2024 included in the HIE Strategic Plan 2023 update as modified and resubmitted by AHS on November 30th, 2023.
Second.
Any board discussion? Anything from the healthcare advocate?
Nothing from us.
Great, thank you. And a public comment on the motion? All those in favor, please say aye.
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 Aye. And the motion carries unanimously. Thank you very much, Kate, and we appreciate walking us through this and the work on working with AHS through this process.
Very well.
Thank you. Is there any old or new business to come before the board? And I will move we adjourn.
Second.
All those in favor, say aye.
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 Aye. We are adjourned. Good afternoon.
Thanks, everyone.
Thank you.